Cranial nerve palsy refers to weakness or paralysis of one or more of the 12 cranial nerves, leading to loss of function in the areas they supply. The clinical presentation depends on the specific nerve involved, the level of the lesion, and whether it affects the motor, sensory, or parasympathetic components. Cranial nerve eye palsy, or olfactory nerve damage, results in anosmia, the loss of the sense of smell. Causes include head trauma with fracture of the cribriform plate, frontal lobe tumors, or viral infections that damage olfactory epithelium or bulbs. It may be unilateral or bilateral and is often one of the earliest findings in neurodegenerative diseases such as Parkinson's and Alzheimer's disease. Cranial nerve 2 palsy, affecting the optic nerve, results in visual loss in the affected eye. Lesions anterior to the optic chiasm cause monocular blindness, while chiasmal lesions cause bitemporal hemianopia, and lesions posterior to the chiasm result in homonymous hemianopia. Causes include optic neuritis, multiple sclerosis, ischemia, trauma, and compressive lesions such as tumors or aneurysms. Cranial nerve 3 palsy, or oculomotor nerve palsy, presents with ptosis due to levator palpebrae superioris weakness, a down and out eye position due to unopposed action of lateral rectus and superior oblique, and pupil dilation if parasympathetic fibers are involved. The most common causes include microvascular ischemia in diabetes, aneurysms, particularly of the posterior communicating artery, trauma, and uncal herniation from raised intracranial pressure. Cranial nerve 4 palsy, affecting the trochlear nerve, leads to weakness of the superior oblique muscle. The patient may have vertical diplopia, especially when looking down and in, as in reading or walking downstairs. The head is typically tilted away from the side of the lesion to compensate. It is the most commonly injured cranial nerve in head trauma due to its long intracranial course and slender diameter. Cranial nerve V palsy, involving the trigeminal nerve, may affect sensory loss over the face, corneal reflex, or cause jaw deviation and weakness of mastication muscles. Trigeminal neuralgia is a classic condition with paroxysmal, lancinating facial pain in the distribution of one or more branches. Lesions may arise from tumors at the cerebellopontine angle, infarcts, herpes zoster, or demyelination in multiple sclerosis. Cranial nerve 6 palsy, or abducens nerve palsy, results in failure of lateral rectus function, leading to horizontal diplopia and medial deviation of the eye, esotropia, on the affected side. It is highly sensitive to increased intracranial pressure due to its long subarachnoid and intradural course. Other causes include microvascular ischemia, trauma, inflammation, and neoplasms. Cranial nerve 7 palsy, or facial nerve palsy, causes weakness of facial muscles on the affected side. In lower motor neuron lesions like Bell's palsy, there is complete ipsilateral facial paralysis including the forehead. In contrast, upper motor neuron lesions such as stroke spare the forehead due to bilateral cortical innervation. Bell's palsy is idiopathic but often linked to viral inflammation, particularly herpes simplex. Other causes include parotid tumors, Lyme disease, middle ear infections, and Ramsay-Hunt syndrome caused by varicella-zoster virus. Cranial nerve 8 palsy involves the vestibulocochlear nerve and manifests with hearing loss, tinnitus, vertigo, imbalance, or nystagmus. Acoustic neuroma or vestibular schwannoma is a classic cause. Other causes include labyrinthitis, Meniere's disease, trauma, ototoxic drugs like aminoglycosides, and vascular insults. Cranial nerve 9 palsy, involving the glossopharyngeal nerve, leads to loss of taste and general sensation in the posterior one-third of the tongue, absent gag reflex on the affected side, and sometimes dysphagia. Causes include brainstem lesions, tumors at the jugular foramen, and inflammatory conditions. Isolated palsy is rare and often occurs with vagus and accessory nerve involvement. Cranial nerve X palsy, affecting the vagus nerve, leads to dysphagia, dysphonia, hoarseness, nasal regurgitation, loss of gag reflex, and deviation of the uvula away from the lesion. Bilateral vagal palsy is life-threatening due to risk of airway compromise. Causes include skull-base tumors, surgical injury, brainstem strokes, or iatrogenic trauma during carotid surgery. Cranial nerve 11 palsy affects the spinal accessory nerve and causes weakness of the sternocleidomastoid and trapezius muscles. The patient may have difficulty turning the head to the opposite side and shoulder droop with impaired shoulder elevation. The nerve is vulnerable during neck dissections, lymph node biopsies, and carotid endarterectomy. Cranial nerve 12 palsy, or hypoglossal nerve palsy, leads to weakness and atrophy of the tongue on the affected side. On protrusion, the tongue deviates toward the side of the lesion. Unilateral lesions may result from stroke, tumors, surgical trauma, or compression from carotid artery aneurysm. Bilateral palsy affects speech and swallowing severely. In summary, cranial nerve palsies reflect dysfunction of specific neural pathways. They provide important clinical clues for localizing neurological lesions. Careful assessment of eye movements, facial symmetry, speech, swallowing, hearing, and reflexes helps identify the nerve involved and guides further investigation and treatment.